Hello, my name is Thomas Cluzeau from Nice University Hospital. The question today is what are the treatment options for transplant ineligible relapsed AML patient following AZA venetoclax based therapy? So it's a difficult question because today in France there is no drug available after azacitidine plus venetoclax, but there is some study ongoing, and we could observe some promising results presented at the last two hash meeting. So I think at relapse, first we have to sequence again the patient to identify maybe some subgroups. So for me, the first subgroup is the IDH1 mutated patient. During the last hash meeting, Marie Seber presented the promising results from idiom study in first line, but also in relapse refractory patient, and we could observe in this subgroup of patient IDH1 mutated an overall response rate around 50%. So it's really interesting in this specific subgroup. For another subgroup, the IDH2 mutated patient, Lionel Hades presented also at the promising results of the ideal study. And in this study, in the subgroup of relapse refractory patients, we observe an overall response rate around 40%. I think maybe we could discuss about another subgroup, maybe the FLT3 mutated patient, because as you know, since 2 years, we have the results of the venetoclax plus gilteritinib. Today there is a phase 1 ongoing study, and the composite complete remission are really high because it's around 80%. So it seems very interesting in this specific subgroup. And for the other patient, it's difficult to discuss today because we have not a lot of patients included in study after azaven failure, but today there is some clinical trial ongoing. One based on CPX351 in combination plus venetoclax or midostaurin in FLT3 mutated patient or enazidenib in IDH mutated patient. This VFAST study is ongoing. For the moment, there is no DLT observed, and we could observe a few patients in response. So for the moment, it seems to be feasible, and it seems to be acceptable for safety. So we have to wait to know if it's a good strategy. And the last point, maybe I think we could include patients in immunotherapy clinical trial. As you know, today there is some immunotherapy. So either conjugated immunotherapy targeting CD33 or CD123. So there is some antibody in evaluation today. We could also maybe include the patient in clinical trial evaluating a bi-specific antibody targeting CD33 CD3 or CD123 CD3, and if we could maybe cite only one because this antibody is in phase 2. It's the flotetuzumab. So the flotetuzumab is an bi-specific antibody targeting CD123 CD3. We observe promising results. So in refractory patients after intensive chemo, but maybe it could be interesting after azacitidine plus venetoclax. Of course, this immunotherapy could be toxic with some cytokine release syndrome. So we have to select fit patient to receive this treatment. So in conclusion, there is no guideline today after AZA plus VEN failure, but we have a lot of drug in development, some targeted therapy, some chemo plus targeted therapy, some immunotherapy, and for me, in this setting, we have to include whole patient in clinical trial to find the good solution for this patient.